Good morning and welcome to our very first virtual Caregiver Cafe. My name is Sarah Amos and I'm the Program Director for Cornerstone Care's Ministry to Caregivers here in Warrenton, Virginia. The Caregiver Cafe is hosted in partnership with Comfort and Care Support, and it was started earlier this year to provide a space for family caregivers to connect with one another, share tips and tricks, learn from local experts, and also just be encouraged by the gift of community and support. We would much rather be able to see you in person today, to shake your hand, to hear your story, and to get to know what the challenges are that you're facing as a caregiver, but also the victories too. But since we can't be together, we're so excited to be able to offer this as a virtual format this morning. We have a great discussion lined up with Smoot and Melanie Shumate on preparing for end-of-life care. Before we dive into that, I'd like to share a little bit more about Cornerstone Cares and Comfort and Care Support. Cornerstone Cares was started in July of 2019 by Cornerstone Baptist Church, who received a grant from the PATH Foundation. We are here to serve family caregivers by supporting them, giving them resources, offering events like these, and I'll show you and tell you a little bit more about what that might look like for us to support you after the webinar today. Comfort and Care Support is another great local organization that's been serving Fauquier County and the surrounding area since 1982. They offer volunteer respite services, bereavement services, and also a great loan closet with durable medical supplies, continence supplies, and nutritional products as well. And they do it all at no cost to the community. We are both so excited to partner together to offer you the Caregiver Cafe. We also have a really great opportunity for you to interact with Anne and Melanie today during our live stream. If you have any specific questions or comments or resources that you're looking for, feel free to drop those in the comment box and Anne and Melanie will be on live to answer and connect you. This is a really great discussion and one that applies to a lot of people. So if you know someone else who would benefit from watching this webinar, please pass along the link and tell us how we can help you or them stay connected. Now, let's join Anne and Melanie as we discuss preparing for end-of-life care. Well, good morning, ladies. I'm so excited to have you here this morning. It's going to be so cool to be able to still connect with you and hear from you, even though we're all separated. So if you just want to go ahead, I think it'd be really great if you could both give a little introduction about yourself.
Good morning. My name is Ann Smoot. I'm a nurse practitioner with Capital Caring, Palliative Care, and Hospice Care. My job is to see patients in the community who have advanced illness and kind of help with symptom management. And so the goal today is just to kind of talk about having a good plan in place, and I look forward to talking to you all about that.
Thanks, Anne. Good morning. I'm Melanie Shumate. I'm a patient advocate with Capital Caring Health, and my role in the community is to provide education as well as build relationships and rapport with partnerships with our other providers in the community. So I'm excited to have this conversation as well. Thanks, Sarah.
Absolutely. We are really excited to have both of you here. It's kind of a 2-for-1 deal. And I think you both just bring such a unique perspective on preparing for end-of-life care. I know that in this season, things are kind of upside down, but I think it's something that is really good to think about and think through for families. So I'm really looking forward to also learning myself too. But Anne, if you want to go ahead and get started, we're looking forward to your presentation.
Sure. I think the big overreaching issue, thought, concern is have a plan. So often I see family who are in crisis and then trying to come up with a plan when they're in crisis. And it just adds so much stress and grief when we would rather just be spending time with our loved one. So the most important part to me when we initiate this conversation, because I don't know this piece of the pie. This is absolutely something that comes from the patient. It comes from the caregivers that know the patient the best. It doesn't come from a provider who is new to the situation. So we have to establish goals of care. And the way that I find is best in establishing goals of care is to discuss it in terms of quality of life. We kind of know for every intervention, there's a risk, there's also a benefit, and weighing the aggressiveness of the intervention against the benefit we hope to derive from it is an important conversation to think about and keep having. So the analogy that I like to use is discussing a farmer who every day of his life has been outside and had his hands in the dirt. And that's where he derives his joy from, his quality of life. If you tell him that you are now bedbound and not able to go outside anymore, is there a quality of life there? And versus somebody who is a little more focused on, let's say, grandma, who takes great pride and joy in watching her grandchildren. Does she have a quality of life if she's able to sit in her rocking chair and watch her grandchildren play? Not so important that she get outside and put her hands in the dirt every day. And so when we start talking about that, it's really important to know your loved one and how and where they derive quality from, and let that guide you when you're making decisions about how aggressive do we want the care provided for them to be. If you have a person who has very end-stage dementia, who spends much of the time with anxiety and fear because they don't recognize their loved ones around them anymore, versus somebody who has beginning stages of dementia who are still able to recognize their loved ones and participate in daily joys. That guides, let's say they have a urinary tract infection, very common in this population. In the first situation where we would think that there's not a lot of quality of life, maybe we forego the IV antibiotics, versus the person who has beginning stages where we say, absolutely, we want IV antibiotic. So it changes over time. And it's good to kind of have a check-in to know where we're at in our continuum, what our quality is versus how aggressive we're willing to be for the things that we're doing with our loved one. The book that breaks this down the best, that I absolutely love, is called Hard Choices for Loving People. And this is written by Frank Dunn, who is a chaplain. So there's a little bit of faith-basedness to it, but it's also very much focused on the nuts and bolts of the science of when is it appropriate to do CPR, when is it appropriate to do tube feeding, artificial nutrition, when is it not? Should we do IV antibiotics? Should we do IV fluids? It puts this in a very digestible, easy to understand form about the benefits versus the burdens of different types of interventions, and helps guide decision making. So absolutely, if you've not seen this book, it's about $4 off of Amazon. It's definitely worth the 45 minutes it takes to read. The other thing that I think that people don't know, and especially our older folks don't know, that is that you're an active participant in coming up with a care plan. And many physicians and providers have a difficult time discussing end-of-life care and prognosis with families. And so I encourage you as a family member or as a patient to give your provider permission by saying things that let them know that you very much want to hear the hard truths. You don't necessarily want them to put the optimistic spin. So if you're wanting to know about prognosis, you have to say, what is the prognosis for dad? If we do this, how much time do we expect to have? What are some of the side effects that we can expect to have? And so in giving your provider permission, it opens up the conversation for a more honest and enlightening conversation, and to help you make choices for goals of care. The resource that I like for this one is Being Mortal by Atul Gawande. He is a surgeon who went through this process with his father. And so he talks about it from a physician standpoint, then he talks about it from a family member standpoint, and does a lot of interviews with both sides of the fence. I think it's an excellent tool. You can find it on Netflix via PBS. as a documentary. You can also find it as in its original form, the book. And so definitely worth taking a look at, just to kind of give you some tools in your box to how to initiate conversations with your provider team. This slide is intentionally not pretty or fun, but more so the nuts and bolts of logistics, which is so important and often gets very overlooked and becomes a big source of burden for many of my families. When we have somebody with advanced illness, the caregiving needs become astronomical. And in this day and age, most folks have a full-time job, and figuring out how to have caregiving for a family member that requires around-the-clock caregiving is really tough for most people. And so this is a plan that has to be started even for me in my middle age. Do I want a long-term care plan? And if I do have a long-term care plan, what's the fine print? Do I have to pay out of pocket for 90 days? Does it provide home care or only facility care? What about assisted living? So all of these kinds of things pay very close attention to if you're thinking about a long-term care plan. The piece that I caution folks about is many people believe that insurance covers caregiving. So the thing to know about most health insurances, Medicare to include private, they pay for a skilled need. So if a person is in the hospital and they need to go for physical rehab for a certain period of time, or they have like IV antibiotics and they need help in the home administering those, insurance covers those skilled things. But it's generally for a very limited time, 30 days, couple weeks, that kind of thing. If we are talking about what's called custodial care, where this is an ongoing need, insurances don't pay for that, Medicare nor private insurances. The only exception to that is Medicaid, and Medicaid is absolutely an income-based program. You have to have a certain income threshold that you can't go above. And so some folks can qualify for Medicaid, many folks cannot. And so it's good to know if you're in a situation that you need caregiving for your loved one, how do you go about getting that? Just because generally it's pretty cost prohibitive for a lot of people. From my standpoint, the prices that I'm seeing is for if you have in-home caregiving for a person to come to your home, it's generally anywhere from $20 to $30 an hour. If you're looking at a facility, it's more like $10,000 to $20,000 a month. So it's something that you can't wait until you need it to start trying to plan it. It may be that you have a large enough family that you can do shifts. It may be that you have, especially in this community, faith-based support and volunteers that can help, but it's a huge thing to start thinking about even in our middle age on through our elderly and caregiving for our parents. So advanced illness management for palliative care, they're kind of synonymous. This is what I do. What is it? What is palliative care? So for different people, it means different things. And so how I use palliative care and how my company uses palliative care is it's an advanced illness management. So let's say you have heart failure and your legs are swelling up and you have a hard time breathing and you're going to the hospital a few times a year. You're appropriate. What if you have cancer and your oncologist agrees that chemotherapy is a good idea, but we know with chemotherapy often comes pain and nausea and some anxiety? You're appropriate. So basically, it's anybody who has a chronic illness with unpleasant symptoms associated with it. It works in conjunction with any treatment plan that you have going with specialists and primary care. Insurance pays for all of those things together. And so it's for folks who have a chronic illness, suffering from some symptoms from it, but are still appropriate and wanting aggressive or curative treatment. Maybe you want a heart stent. Maybe you're looking to be on a transplant list. Maybe you're looking for skilled nursing care. All of those reasons are good reasons to have palliative care in conjunction with your treatment team for whatever other treatments that you're receiving. How do I get it? This is something you talk to your primary care doctor about. You tell them that, hey, I'm just really struggling to get here to my appointments. I'm having symptoms, and they know how to initiate that for you. The other thing that you can do is you can self-refer, and in this brochure, that's a 24-hour line for capital caring specifically, but you can also Google search other providers as well for our local area and just self-refer to them as well to say, hey, look, I'm taking care of Dad. He's in a lot of pain, and I really need some help. And they'll be able to kind of talk through and initiate services and contact your primary care provider and get that going for you. And how is it paid for? So palliative care is covered by the vast majority of insurances, to include Medicare. The thing that I caution people about is that there is very often a copay associated with it. It's not entirely covered. And the copay is generally very similar to what your specialty doctor visit is. So if you pay a $30 copay to see a cardiologist, then you would pay a $30 copay for the palliative care provider to come into your home. And so then the next thing we talk about is hospice. What is it? So similar to palliative care, hospice is very much focused on symptom management. And so what I tell folks is the medical team, whether that's hospital, primary care, your specialists like cardiology or pulmonology, their job and what they're very good at is giving longevity. How to make me live longer. Hospice's primary focus is not necessarily longevity, but making sure that we have a quality of life and that we are comfortable. Very often the two mesh very well and you get both. Symptom management, because if you have heart failure or COPD, very much your medical team is going to be focused on how to keep you breathing well and how to keep you feeling comfortable. But sometimes longevity conflicts with comfort. There's a time when the disease is so advanced that to help the heart, we hurt the kidneys, or to help the lungs, we hurt the heart. And so then we have to start making choices about what our goals are and how to best go about it. Who's appropriate for hospice care? There is a whole book of eligibility that Medicare puts out that is a guide for doctors and physicians that tell for under what disease or chronic illness, what the qualifying aspects are. But what research has told us is that if you look at your loved one and you say, I would not be surprised if Dad passed in 6 months to a year, they are very likely appropriate for hospice care, and that is the best determinant ever. So if we have COPD and we're getting pneumonia, and we're scared the next time we get pneumonia, we're not going to make it out of the hospital. They're appropriate. If we have heart failure and we're sitting in our chair and not moving around very much because we lose our breath so badly, you're appropriate. If you have a cancer and you've decided really don't, or your oncologist has told you not very interested in chemotherapy, not interested in radiation, these are all people who are very appropriate for hospice. It doesn't need to be that they're imminently ill. Many of our folks are on hospice for several months to a year. Some of our people graduate from hospice because they improve, their symptoms are managed well enough that they improve and they don't need our services for a year or two. So it's not a death sentence that if you sign up for hospice. It's a way to bring additional resources into the home and get good symptom management going. Resources that come with hospice is a nurse case manager that comes to visit the home once a week. It's 24-hour after-hour support. So if 2 o'clock in the morning, dad wakes up, he's agitated and confused and having a hard time catching his breath, you call a number, a nurse comes and visits and helps you get symptoms under control. It's medical equipment that you need in the bed or in the home, like a hospital bed, like an oxygen tank, like incontinence supplies, those types of things. Oh my gosh, the unsung hero is the nurse's aide. She comes, or he comes into the home 3 to 5 days a week for about an hour at a time to help with things like bathing, changing bed sheets, those personal care things that just make the patient feel better. I've been told so many times that, oh my gosh, it has been so long since my hair has been washed. That was the best thing ever. So I love our CNAs. The other person that comes with it is a social worker. One of my social worker friends told me, tell people I want to come into their home and hear about their love stories, because everybody has a love story, whether it's a love for their child, love for their pet, love for their husband or wife. She wants to hear about it. The other thing that I love social work for is resource planning. How do we get community resources into the home to make the situation a bit more easy to deal with? And then the final person that I'll talk about is the chaplain. He is a person, or she is a person that can come from not necessarily a secular, but can be secular. He's the person that comes, will pray for you, will sing with you. One of our chaplains brings a guitar and plays the guitar for you. You can be Christian, you can be Catholic, you can be Muslim, you can be atheist, and our chaplain will still provide the support in a way that is comforting to you. How do I get hospice? This is also a similar situation where you can call a number and self-refer, and our care navigation team will assist you in getting a hold of your primary care provider and getting into the process. Or your primary care provider can also initiate the process for you. How is it paid for? Medicare and Medicaid pay for the hospice benefit 100% without any copays. Let's see, private insurances, sometimes there can be a copay if the deductible has not been met. Usually that's a very affordable copay. Let's see. And similar to palliative care, this is our 1-800 number that you can self-refer to, but also a Google search. If you have an agency that you're more comfortable with, absolutely, you can find other providers in the area. And then this just talks a little more in depth, and Melanie is going to provide access to this so that you have time to look through and read. Advanced medical directives. This is a tough one. So this is all part of have a plan. In the beginning, I talked about families in crisis. If dad has had a serious acute incident and you're in the emergency room and the doctor is saying, do we intubate? Do we do CPR? What do you want us to do right now? And you as a child or a spouse are saying, I don't know. And there's a few people involved saying, well, I think. A very scary time with a lot of confrontation is exacerbated. And then there's usually a good bit of fear and guilt that I maybe made the wrong decision. This isn't what mom wanted. This is what dad wanted. I don't know what they wanted. So I encourage everybody, whether you're 15 or 105, start having discussions about advanced directives and how you want to be managed should an acute thing happen. So the first thing that I'm going to talk to you about is the how to get a free advanced directive. You can go through your lawyer, and often it's fairly pricey, but you don't need to do it. There's a lot of free resources. The Inova website has a free advanced directive, a medical directive that is very easy to access, and I've included that website. And the second website includes all, in many different languages. I think they had 10 different languages that this form is provided in. And it's very much the patient and 2 witnesses that go through this form. The cautionary piece is there's legal language that I'm not comfortable with, and that I think the average layperson wouldn't be entirely comfortable with. And so you may want legal representation to really understand what you're going through and what you're signing. That brings us to the next one. This is called the 5 wishes. And I like this medical advanced directive a lot because the conversation, I feel like, is just as important, if not more important than the actual form. This book takes you through the conversation, and it's very much written for the lay person, not the legal person. And so things that it addresses that I really like: the person I want to make care decisions for me when I cannot, the kind of medical treatment I want or do not want, how comfortable I want to be, how I want people to treat me, what I want my loved ones to know, what are the things that are most important to me. So these are the 5 wishes, and each page is about 12 pages. Each page talks you through that and gives you a bit of space to write in your answers. And this is very much an advanced directive that is recognized as a legal form. Post versus community DNR. Community DNR, this is the form that most folks are most comfortable with. If an EMS provider comes to your house because you've dialed 911, this is a form that they immediately recognize and tells them what to do or what not to do. And that brings us to our first bullet, code status. What is my code status, and what does that even mean? What that means is, am I a full code, which means I want you to do everything you possibly can to try to keep me alive. It means I want you to intubate, put a tube down my throat, and use mechanical ventilation to keep me breathing if I stop breathing. It means I want CPR, where you do chest compressions to try to restart my heart should it stop beating. That's full code. DNR means strictly the opposite of that. It means do not resuscitate. I know that CPR is a violent, difficult process for somebody who is elderly and frail. So CPR initially, when it was first brought about as a treatment method, was meant for young, healthy people who met with an accident, i.e. a 12-year-old drowned victim. And CPR worked very well in that population in bringing the person back to a fairly functional life. But so we started expanding the scope of that. And now, in my personal opinion, many folks who are not appropriate to get CPR are now getting CPR. The thing that I caution folks to know is that in well over 98% of our elderly population that we do CPR in, are we able to get a pulse back. And of that 90%, a significant amount of them have hypoxic brain injuries, which means that the functioning person that they had prior to this intervention doesn't come back very well. Rather, there's just significant brain injury. And so I think that's very important for families to know and people to know, because we live in this age of Grey's Anatomy where we do a couple little pushes on the chest and the person comes back and they're exactly who they were. I think it's a disservice for folks not to understand the possible, that CPR doesn't look like that. I think it's important to have an informed decision when making a decision, rather you want to be full code versus a DNR, do not resuscitate. The final form that we talk about is the post order. I like this form a lot because it makes the person or their medical designee, it helps you be very informed and be very much in charge of what your treatment plan is. And this is a physician order that becomes part of your medical chart that must be and will be adhered to. And nobody beyond the person who filled this form out, i.e. the patient or the medical designee, can change this form. So the first part of this form is your code status. Just like this form that we talked about, this part up here covers that. Are you a full code or are you a do not resuscitate? Now, there's a whole lot of stuff in between that. And you may say, look, there's some things that I don't want, but there's some things that I do want. And how do I communicate that? This form is excellent in going over that and talking about it. So the first part, full code versus DNR. The second part kind of talks about your hospitalization thoughts. So if I were to get sick, do we want to manage that illness at home with a focus on quality, i.e. comfort? Are we more interested in managing pain and managing difficulty breathing? Or simply put, are we interested in comfort measures? Or are we more interested in interventions? And how much interventions are we interested in? You might be interested in ICU level, intensive care unit level of intervention, i.e. you do want to be intubated with artificial respirations. You do want the IV drips that help you maintain a blood pressure. Anything that can be done to give you longevity, you want that. So that goes on in this form. Or you may say, let's do something in the middle. I'm not interested in having the tube. I'm not interested in them trying to maintain a blood pressure, but gosh, I have a really bad UTI, and so I am interested in IV antibiotics. I would like that. a medical surgical level of care in the hospital. So then you could select that. Or you could say, really, quality of life is not what I want. I'm really not interested in prolonging life. I want to more focus on comfort. And so then you select that. And then the other portion, the next portion we talk about is artificially administered nutrition, tube feeding, IV nutrition. Is that something we want to have or something that we don't want to have? And when making this decision, especially, I think it's super important. We talked about that book towards the beginning of the presentation, Hard Choices for Healthy, or Hard Choices for Loving People. That book really talks to you about the benefits versus the burdens of that intervention, especially. Many people believe that if you withdraw or don't provide artificial nutrition, that you're starving a person to death. That book really talks about how smart the body is in being able to manage symptoms in the body as we start nearing the end stages of our life, and how medicine, if we bypass or overrule those processes, it really causes a lot of discomfort. And so it's important to make an informed decision in this regard as well. Is their body at a point that if we do artificial nutrition, are they going to be able to process it properly to give them longevity without causing a disproportionate amount of discomfort? So absolutely, again, I recommend reading that book prior to making decisions like this. And then the last piece is where the patient signs, as well as the provider having the conversation signs. And this, again, is an actual physician order that has to be followed once it becomes part of the medical chart and cannot be changed by anybody except the person who executed it. So it's a good form to have. Who is it appropriate for? Similar to palliative care or hospice, post is appropriate for somebody who is expected to have about a year, give or take, of time left with us. So somebody who has a chronic illness that is nearing end stages. Whereas the 5 wishes, that's much more appropriate for very early on. I could do a 5 wishes. It may change over time as I go through my stages of life, but 5 wishes is very much appropriate for everybody. And that concludes my discussion points. It's Melanie's turn to talk, or for Ms. Sarah to ask questions if we have any.
And thank you so much. I think you did a great job of really taking a lot of terms that I know people struggle with to understand the differences of between them. And I think you did a really good job of just kind of breaking it down in a way that's very easy to understand. So we really appreciate your thoughts and just making it much more approachable for us, this topic in general. So Melanie, we'd like to pass it over to you. You are very equipped in passing resources along to families. And so I'm really excited just to hear what resources you think are valuable and how those people can get those.
Okay, so I'm going to share. So I'm going to kind of recap what Anne went over and just provide the resources to kind of help people connect with, starting the conversation. That was Anne's very first slide. How do we initiate those conversations? Because it is difficult. Kids don't want to hear about mom or dad talk about their end of life planning, and parents don't want to burden children sometimes, or they think it's a burden. So how do we start this conversation? So Capital Caring has this wonderful initiative called Starting the Conversation, and it's a little brochure that gives step-by-step instructions on how to have this conversation. And and to keep it going until it's finalized. And, you know, we've done a couple Being Mortal events in the community, and sometimes we open it up to conversations, and some of the conversations are, I wish I would have had this information when I talked to my loved one about it. So it's a great way to kind of keep things flowing and going. Anne talked about the 5 wishes. So again, you can copy and paste this link into your browser, and it'll take you right to a copy of the 5 wishes. Very step-by-step, easy to fill out guidance along the way. There are additional forms that Anne talked about, you know, appointing a healthcare proxy, the post form, which is the physician order for scope of treatment, power of attorney forms for medical, property, and financial. It's important to have all 3 of those in place. So you can find those here. We also have links to AARP. They have free printable advanced directives. You can go to the Virginia Post website and kind of look at the steps to go at getting one. You can look at the form to see, you know, the really get into the nitty gritty of what you're going to be making choices about. And then there's powerofattorney.com. So lots of resources. As caregivers, when we move into that role, there's a lot of questions, you know, what do I do? So Capital Caring does have a lot of brochures that are, again, the step-by-step, kind of take you through the process. So I put those links on here as well. We have Taking Care of Elderly Parents, talking to your parent's doctor and how to do that. This one is a great resource. It's got the capability to write notes, ask questions, so that you can take it visit to visit and kind of keep track of everything that's going on. When you're in front of the doctor, you can pull out the page that has the questions so you don't forget to ask those questions. If you have someone that you're taking care of that you think might have dementia, there's a brochure that will take you step by step on dealing with that, coping with that, getting that person the care that they need. And then when is it time for hospice? Just kind of preparing you for who's eligible, what steps to take, and kind of guiding that process. And then like Anne said, she showed you the brochures. So we have the Advanced Illness Care, which is palliative care, brochure available. So again, just copy the link and put it in your browser and it should go right to it. Lots of good information in there. Same with the hospice care. And then we also at Capital Caring, we have a veterans health and support services line. So, if your loved one is a veteran and you need some additional support or help with benefits or a little bit of extra guidance on who to go to, please reach out and we'll help navigate that. Again, I'll put our number here. If there's any questions about any of our services, people can call 24/7 or visit our website at any time. And then within the community, we've got the Fauquier, Rappahannock, Rapidan Community Services Board, Fauquier County Social Services. If you need to apply for Medicaid or you're not sure if your loved one would qualify, you can go on either of these 2 websites, make a call to social services and have them talk you through the process. Aging Together is a great resource for our senior population. They're staying up to date on every current situation that's going on as we are in this pandemic and what resources there are, and how the community partners are coming together to provide support for our seniors. And then we have the resource guides. Lots of great information on those, different service providers, all kinds of really anything and everything that you would need is in these resource guides within the communities. So those are on there. This list is not exhaustive by any means. There's a ton more, but I didn't want to put like a 5-pager resource. Could be overwhelming. So, that's there, and we'll make sure that it's available to any of the viewers out there.
Thank you, Melanie. Those are really awesome resources, and I think I really appreciate that you put the link so everyone can access those. I think the best way to do that is we can make it available on our website, cstonecares.org, or I can email them out to people as well. So before we get going, I just want to take advantage of having both of you here and just ask a few questions, things that might be on people's minds as they think about preparing for end-of-life care. The first question I have is, obviously, this is a pretty sore subject in some families. You know, people don't really want to think about those late stages of care. Caregivers are in it for the long haul a lot of times, and when it does come to that time of preparing for the end, a lot of people get anxious or they just don't know how to start those conversations. So whether someone's already caregiving or they think they might be a caregiver, what are some tips for starting those conversations about end-of-life care?
So I say have it early, have it often. It doesn't need to be a 2-hour conversation where everybody's sat down with grim faces. It's maybe, hey mom, what do you think about this? 5 minutes while you're driving to the grocery store kind of thing. You can do it in increments, just to get touch or feelers out there about what it is that's going on. It doesn't need to be this huge gloom and doom conversation where you sit down and we're gonna hash this out in an hour, no matter who's crying. Yeah. Versus we have a pastor who says that his parents sat he and his brother down and said that, look, I have some property we just bought and want to show you. Well, parents had bought a gravesite, and son was like, yeah, Dad, not funny. But it was a lighthearted way. And so it's creative as your mind is how you do it, because you know your family member better than anyone. So if you can do it in small increments over time versus a big heavy conversation where folks tune out and maybe aren't able to process and be present like you would want them to be.
That's great. I think a lot of people rush into those conversations and make it a big thing when maybe just over time it can be something that you work through. So that's great advice. Yeah. Melanie, did you want to add anything to that?
I mean, yeah. So I think having that conversation, it can be a little bit difficult, and it does bring a lot of family dynamics to the table if you just sit down and schedule a time to say, we're all going to get together and talk about what mom, what we want to do for mom. Well, it's not what we want to do. It's about what mom wants. So sometimes even, because we're middle-aged, well, I am anyway, I could start the conversation with, you know what, mom, or dad, or whomever I'm having the conversation with, just so you know, I don't want A, B, and C. So if I'm not able to make that choice, I want you to know that. And that might kind of open up the conversation for them to say, well, you know what, I don't want that either. So if it ever comes up, and then you can just have I don't know that it's ever going to be lighthearted, but at least it'll be open and back and forth, and you've initiated that conversation so that the next time you come back to it, it's not quite so walls up and shut down. So I just think, keeping an open mind and, knowing that in the end, it's because you love someone so much that you want to do what they want instead of what you want, which I think is hard, especially as kids. Because, if I didn't know what my parents wanted, I would probably enter it and say, do everything you can to save my parent, not thinking about what that would mean, what life would look like for them after I've made all these decisions. So I think it's important to know. So thank you for sharing that, Anne. That's wonderful.
Absolutely. Thank you. Those are both really great perspectives on how to start tough conversations, for sure. Mm-hmm. My next question is, a lot of people find themselves kind of stumbling upon the end of life season. The doctor tells them it's time to move to hospice care. So my question for you is, what, being in the field for as long as you have, what are the best allies people can rely on in that end of life care? So whether it's a resource, someone to reach out to, a book, I think, Anne, you shared some, but what are some good allies people can rely on in that stage of care?
That's a hard one. So caregiving is the most difficult barrier for many families. And so finding resources for that, rather it's through the faith community, the church volunteers, to knowing that you can ask friends and families for help and being very direct with the kind of help you need. Man, I just need somebody to come sit with grandma for 4 hours every Saturday. Who can do that for me? Oh my gosh, meal planning is difficult. Who can bring meals once a week for me? So having specific things that you need and then finding folks who can fill those needs. Opening up the family to say that, okay, mom lives with me, but I can't do this 24/7, and figuring out a share plan, because it's going to take some working together. Nobody can do it by themselves. So there again, I plan ahead. Don't wait until you're in the moment.
Yeah.
Yeah. I mean, it's such an emotional journey when you're facing your own mortality, or your loved ones. So I think, talking about it, embracing it, and sharing it, there's no shame in sharing. There's no, having somebody that you can talk to, a confidant, a religious leader, your church family, whomever gives you that peace and that comfort that you can share openly with to help you navigate those feelings, because it's an emotional journey, and it's, unfortunately there's some guilt that comes along with that. You can't make things better, and you can't do it all by yourself. So knowing that there's support out there, with hospice, there's social worker, there's grief counselors, there's lots of services, the chaplain, that you can rely on to communicate with and share, and they can help you cope and give you skills and things to help navigate those feelings and learn to process.
That's great. Yeah, I think you guys really hit on the fact that it takes a full team of people. It's not just one person, and it can't just be one caregiver. Our ministry, Cornerstone Cares, and also Comfort and Care Support, which is another non-medical hospice here that we partner with to put this on, both were really enthusiastic about being part of that support system. We come at it from a more spiritual side, and Comfort and Care from a more companionship side. So, and Capital Caring is obviously a great resource as well. So there's a lot to go around, and a lot to people to be on board in that season. My last question for you is on self-care. So self-care and caregiving is so important, but it kind of takes a different role in the end stage of care, because a lot of times people don't want to leave their loved one. Those hours are really meaningful. They're really important. So what does self-care look like when you're in this kind of late stage of caregiving, and what are some best practices that you guys have seen?
I think it's huge to recognize that we're human. We can't do it all by ourselves. I am a nurse practitioner now. Before that, I was a bedside nurse. I take care of people 8 to 12 hours a day. And then I go home and I rejuvenate. I read a book. I have a glass of wine. I spend time with friends. I have time for me. And then I go back to work the next day, and I can be good at my job. When you're in the home and a caregiver, it is imperative that you get help and know that you cannot do it by yourself. It is just not humanly possible. It is too exhausting. It is too draining. It is too difficult to do by yourself. I always use the analogy, and I hear other people use it as well because it's so fitting. When you ride on the airplane and you get your safety briefing, what is the thing that they always say? In order to help your neighbor, you have to put on your mask first. And I believe that is very true in caregiving. The other piece that I think is just huge is that bring hospice in, bring sooner rather than later, because you need to be a family member. You need to be the loving daughter, not the medical provider. So if you can bring help into the home to do the more mundane tasks, It lets you have a little emotional energy and physical energy to be the loved one versus the caregiver. I think it's really important to bring in as much help as you can, as early as you can.
Great.
Yeah, I agree. I think, it's hard to be a caregiver, I know, but accept help when it's offered. Ask for help when you need it. Um, go on vacations, continue to live. That's what your loved one would want. There's great resources that come along with hospice, possibly looking at, 3 to 5 or more days of respite to give you that break, to get time to rejuvenate, bringing in a caregiver temporarily, a paid caregiver, just to give you a break. There's caregiver services that can come in, even volunteer services that can come in and sit with your loved one so you can run to the store, or go get your hair done, or go get your nails done, things that just help you continue to caregive with that love and compassion without burning yourself out. So just taking advantage of those resources that's there is critically important, because your job is amazing and extremely difficult. So yeah, that's accept the help.
Absolutely. Thank you, ladies, so much for your time this morning. It has been just a delight to hear more and learn from you and glean from your expertise. If people wanted to get in contact with either of you, is there a good number for them to call or a good website for them to visit that would get them in touch with you?
Okay, so capitalcaring.org is our company website, and I don't know if people have been on it in the past. It was a bit clunky and not easy to navigate. It's had a significant facelift, and it's very interactive and very user-friendly now. So I would encourage you to go there because it kind of talks you through and gives brochures and resources and has an online chat function that is very user-friendly. The 1-800 number that Mel shared is also a great resource if you're trying to get services on board and aren't quite sure which ones you want or need. The care navigation specialists are wonderful in being able to kind of talk to you about what's going on with your loved one and where you would best fit in the healthcare continuum with us.
Yeah, like Ann said, the care navigation, our care specialists are qualified and very knowledgeable on navigating which service folks could benefit the most from. If you have questions about eligibility and things of that nature, they can answer those. And that's on the resource list that I had, so we'll make that available. And I'll put both Ann and my numbers on there as well.
That's great. All right. Thank you, ladies, so much for your time. I appreciate that you were being willing to be flexible and that we could still offer this Caregiver Cafe even if we couldn't all be together. And hopefully we'll all be back together soon. So thank you, ladies. I hope you have a wonderful day, and I hope everyone else has a great day too.
You too. Stay healthy.
What a great presentation that had some valuable information, helped us to kind of sift through some of those big terms we often hear when we think about preparing for end-of-life care, and also just make a little bit more sense of those late stages of caregiving. We're so grateful for Ann and Melanie for sharing their time and their expertise this morning. They'll be online for a few more minutes, so if you have any specific questions, you can feel free to drop those in the comment box. If you'd like access to the resource list that Melanie shared today, you can email us at caregiving@cornerstoneva.org or visit our website, Seastone Cares. Before we depart, I really just want to share one more thing with you. When we were thinking about the elements we wanted to include in a Caregiver Cafe, we realized just how important it is to include a caregiver's story. It is an opportunity for you and for all of us to realize that we're not alone as caregivers or in anything that we face, that other people are going through similar challenges, but if we all band together, we can be mutually encouraged. So here to tell you a little bit more about Cornerstone Cares and also his caregiving journey and ways Cornerstone Cares was helpful to him, we'd like to share Charlie's story. My name is Sarah Amos, and I'm the Program Director for Cornerstone Cares. Cornerstone Cares is a ministry that was founded in 2019 to partner with and support caregivers in our local community. We realize that the caregiving journey can often be full of challenges, highs and lows, and caregivers often feel really lonely. Our desire through this ministry is to build partnerships with caregivers and help them to know that they don't have to face those challenges alone.
My name is Charles A. Halt, and I'm going to tell you a little story. My wife, in October of 2018, woke up one morning and she was not exactly where she was supposed to be. She was not paying attention. She was not listening. And on October 31st of 2018, they operated to remove a large mass from my wife's brain. 3 weeks later, they informed us that my wife had glioblastoma class 4, the most aggressive type of brain cancer that's known. So on October 1st of 2019, I became a full-time caregiver. I can tell you right now, if you ever get thrust into that situation, you quickly realized how you can become overwhelmed and just feel like you're just going to shrivel up and you want to go into a corner and hide. But you have a choice. If you do that, then the person who depends on you is not going to make it. At the time, a coworker of mine, Tim Klontz, let me know that his church had this outreach program called Cornerstone Caring.
One way that we partner with caregivers is through our Caregiver Advocate program. In this program, we connect a Cornerstone member with a caregiver in need of extra support or encouragement. The Caregiver Advocate will make weekly phone calls, make visits, and even connect them to helpful resources.
I decided to become a caregiver advocate. Just something that was just on my heart, been desiring, asking the Lord about what more is there for me to do. And a member of our church approached me one Sunday and just asked me if I would be interested. And I was just like shocked and just like, wow, God, I guess you have just answered my prayer, I believe. So, yeah, so from then, it's just been a wonderful, wonderful experience.
They came in like a ray of sunshine, and suddenly food started arriving, and we started getting visits.
I got to know Charlie through many experiences. One through a home visit in his home the first time I visited. And when he opened the door, he was just such a bright, cheerful person, very warm, welcoming. He just made us feel right at home.
Lynn had a very warped sense of humor, just like me. I love it. But she enjoyed having them come and joke with her and asking her questions. And even as she got worse and things, and we'd be talking, and she'd be very quiet every once in a while. She'd pipe in and say something that would just catch us all off guard. She was listening after all. Pam and Sarah had an energy. They would come in and they would ask what they could do to help. But I think the most important thing is when you bring folks in, when people come in, that they connect with you too.
Once a week, I would give Charlie a call and just check in with him and just touch base with him, find out if he was able to make connections through the resources that we were able to provide for him at that time. And he was very open, and he let me know the progress he was making, and it was very, very, very encouraging.
As a caregiver, it gave me the feeling that I wasn't alone. Normal, everyday conversation that engages you or engages those that are being cared for is essential. It makes them feel like they're part of the world again. And that's something that's very special.
I just saw how he was just so loving toward his loved one, and it just really just touched my heart.
Our vision for this ministry is to come alongside caregivers and equip them and empower them to walk out their caregiver journey with hope.
So let me tell you, any group like Cornerstone Caring helps. The support, the understanding, the help with resources, the help with food, just being there. That's the number one thing. You need somebody on your side.
Just to see the light to come back into a caregiver's eyes, to know, hey, I'm not alone. There's people out here that really care, and most of all, God loves them and cares about them.
It allowed me to step back and take a little time for myself. And as a caregiver, when you're in this position, you want to make sure that you take time for yourself, or you're going to crack.
What makes me excited about it is because at once I was a caregiver personally myself, and just to be on the other side, to know what it means, it means so much just to have that rest and just to know that someone is there that cares about you. So that's what I look forward to, and just see that hope that rises in a caregiver.
So use all the resources. Pam, Sarah, this whole group was wonderful. Lynn lost her battle with cancer, but her last month, she spent a month, actually a month and 7 days with me. And it was very special to have that month and 7 days. So to caregivers, I can say, if you have a loved one out there, reach out. Find out what is in the area. Don't try to do it on your own. Family, friends, Cornerstone Caring, any group. Reach out. Ask them for help.
If you're interested in connecting with Cornerstone Cares, you can visit our website at cstonecares.org or visit us on Facebook. We hope to connect with you soon. Thank you so much for joining us this morning for our very first virtual Caregiver Cafe. We've really enjoyed being able to connect with you even if we're far apart. These are very strange times. And with all that said, if there's any way that either of our organizations, Comfort and Care Support, Cornerstone Cares, or even Capital Caring, can be of assistance to you in these times, please do not hesitate to reach out to us. That's all for today, and I hope you have a great one.